So in the case of COVID-19, the principles behind case identification and contact tracing do seem straightforward enough. Reach out to someone who's tested positive for the virus and notify as many of their recent contacts as possible. Monitor the individual with known infection for symptoms and ask everyone to isolate or quarantine, depending on their status, for a specified number of days or a few weeks. Except, who's calling? Do I know you? How did you get my number? I'm in no position to stay home, and if I don't go to work, I won't get paid. We live in a small apartment. Who's going to do the grocery shopping? These questions, well, definitely my invention, do in fact represent real issues in this pandemic, especially in the US, around trust, maybe immigration status, cultural sensitivity, and economic realities, just to name a few. And they're all part of this complex web of contact tracing that does need to be factored into the strategy if it's going to prevent viral spread. So keep these issues in mind and all your own questions and curiosities as we dive into contact tracing on this virtual learning hour, and with two people who very much know what they're talking about on this topic. I want to welcome John Welch. He's a senior nurse anesthetist and he's the Director of Operations and Partnerships for the Partners in Health Mass COVID Response and Executive Director for the Massachusetts Community Tracing Collaborative. Shreya Kangovi is the founding executive director of the Penn Center for Community Health Workers and an associate professor at the University of Pennsylvania Perelman School of Medicine. Dr. Kangovi led the team that designed IMPACT, and that's a standardized, scalable program that leverages community health workers to improve health. And we're welcoming back IHI's Don Berwick and Derek Feely. They're our regular expert panelists on these virtual learning hours. So hello, everybody. Thanks for making the time for the program. And hello to everyone joining us. You're going to hear from our panel and our back and forth for about 30 minutes, and then we'll turn to Q&A and discussion. Feel free to chat in at any time and exchange ideas throughout our hour together. So I'm going to start with Derek. There's a lot riding on contact tracing as a fundamental public health strategy, including the hope that it prevents a second wave of the pandemic. There's also a lot of attention to it now with all the reopening going on. So we all agree on that, but we, IHI and others, also want to consider contact tracing through the lens and goals of equity in this pandemic. And Derek's going to connect some of those dots for us. Thanks, Derek.
Thank you, Madge, and happy to try to do that. But before I do, I want to thank you and the other IHI staff on the call today, because you've given up what is a public holiday at IHI. This is Juneteenth. And more to say about the origins of Juneteenth later in the show. But if any of our participants are also giving up their Juneteenth holiday, and then thank you for doing that to join us today. So Madge, you're absolutely right. Contact tracing is a fundamental part of outbreak control. It's used by public health professionals across the world. It's long been a pillar of disease control, but it's been brought, I think, more into the public consciousness over the last few months than perhaps it has been in the past. And the detailed pictures that it can create can act as an essential guide to us as we seek to manage our way through COVID-19 and out of the other side. But as you say, Madge, we know there have been some particular challenges around COVID-19. So how do we make sure that those detailed pictures I talked about are comprehensive in their coverage? We know, and we've discussed on this show, that COVID-19 has had its severest impact in communities of colour. So how do we make sure that contact tracing reaches those communities? If it doesn't, then there's at least the possibility that inequities will widen rather than narrow. How can we mobilise people from those communities to trace, and interact with trust and empathy. And I know we'll be exploring that with Shreya, and I'm sure John will have something to say about that too. And we've seen all sorts of approaches begin to emerge from across the United States and indeed beyond, including in some states the use of the National Guard as contact tracers, which seems somewhat suboptimal from my point of view in terms of how do we create community trust and empathy. Then I think there's a second set of issues about how do we secure the right workforce. So no more than a handful of states are in the right kind of position. If you look at the George Washington University contact tracing estimator tool, then they estimate something like 7 states might be getting close to having the right kind of contact tracing capacity in the state. So we don't have nearly enough contact tracers, and we're not ramping up quickly enough. And I think there are questions also about, do we have the right skills and the right values in our contact tracing workforce? And then I think there's a third set of issues that I hope we'll get to today, which is how do we overcome the patchwork of different public health governance systems that exist? For me, and I'm also sure that John and Shreya will touch on this, this needs a collaborative approach. It needs a learning-based approach so that we can harness the best of practices and apply them widely. And then the fourth challenge, Madge, is how do we secure funding in a way that enables equitable rollout of contact tracing? And the human and the social and the economic risks of not finding that funding are unthinkable. And so we, in order to come safely out the other side of this epidemic, we need to put some of this in place, and we need to do it quickly. And I'm sure John and Shreya are going to help us understand how better to do that. Looking forward to the conversation, Madge.
Thanks so much, Derek. All right, John Welch, we do turn to you from Partners in Health. As probably a lot of people know who've joined us, starting with the governor of the state of Massachusetts, Charlie Baker. In early April, governors and health departments from around the country have been turning to Partners in Health and other orgs to guide them in setting up contact tracing programs. And as Derek suggests, it's kind of a patchwork as to what's really going on around the country. So how would you characterize it, perhaps from the Partners in Health lens? And we welcome hearing kind of your assessment of how things are going. Thanks a lot, John.
Thank you so much. It's really a pleasure and an honor to be with everybody today. So thanks for the opportunity. And hi to everybody from, I'm seeing the little chats coming through from all the places where everybody's joining us. So that's really great. You know, Partners in Health is really drawing on what you can see here is our experience from all around the world. You know, we employ over 10,000 community health workers across the world in various capacities. But what we've learned over nearly 4 decades of doing community-based work in the healthcare arena is that it's absolutely founded on partnership. And I think Derek alluded to that. Everywhere we work is at the invitation of the local Ministry of Health, and in the capacity that the countries and the communities where we work are asking us to participate. So you can see what that work looks like all around the world here on this map. My experience in doing some of this work is drawn from my time in West Africa during the Ebola epidemic, and understanding that first and foremost in any sort of public health intervention is that all epidemics are local, right? So we have to start at the local space and understand the context of where we're, where we're operating, but also the capacity that's there and the capacity that we can either amplify or alter. And I think the same was true in Massachusetts. So we can go to the next slide. I don't know if there we go. Thanks. So, I think the question, at least early on for us, was when will contact tracing really start at the scale that we believe that it needed to really make an effect. And we, this op-ed by Jim Kim, one of our co-founders and the former president of the World Bank, asked exactly that question, saying, we know that there are public health tools as part of a comprehensive approach that can be used to really quell and help slow the transmission. You can see that on this graph from the right side here, which is looking at some numbers from Wuhan that showed an R naught, or the reproduction rate, close to 4. That tapered off to just over 1 with some strategies to try to mitigate the spread. That's stay-at-home orders and social distancing. But once you begin contact tracing and then provide supported quarantine and isolation, you can move that R naught under 1 and really not just break the chains of transmission, but stop the epidemic. And until you have a not just a vaccine, right, but a global vaccination campaign, and you're continuing to support those individuals through that time, you've got to rely on these tried and true public health measures, and they have to be taken in equal measure. That's testing, of course, contact tracing, supported isolation, and treatment. Our strategy in Massachusetts, you can, thanks. We sort of suggested this. Jim Kim and others spoke with our governor, Charlie Baker, and talked about this being a really important tool for Massachusetts, the United States, and the world to stem the tide of COVID. And I think in having that conversation, we were able to push forward this idea that it's not just any one piece of this. I don't know if everybody remembers from a number of months back, but we talked about things like ventilators and PPE, and really focused on those things. And then we started to talk about testing. The thing that PIH tried to bring to the conversation, at least here in Massachusetts, is that all of those things are important, but they have to be all taken together. And so this sort of became the strategy: testing, tracing, isolation, but the support piece. And I think this is what brings us into the conversation around equity. This brings us into the conversation around what a comprehensive COVID strategy looks like, and it's got to be using that supportive structure. We can look at who the partners are. This is not Partners in Health alone. I'll be very clear. So Massachusetts has its command center, who does provide us our overall direction. We're very deeply tied to the Department of Public Health, who helps guide our policy and procedures and all of these things. The local boards of health and local health departments is really one of the most important partners for us, in that we have a constant dialogue throughout every single day between our team and the teams. We're working virtually, and the teams there are the sort of boots on the ground. with the local context, who understand what resources exist there in these communities and how best we can tap into them. We've, of course, hired and deployed the workforce. We'll talk about who that workforce is in just a second. The Commonwealth Health Insurance Connector is really sort of the overall administrator of the tracing collaborative. And we also have had a great opportunity to subcontract with dozens of community health centers from around Massachusetts, which have really bolstered our workforce and been that community, that connection back to the community. And those folks are often able to be the voice that so many of the cases in their contacts are looking for. If we talk about, hi, my name's John, I'm calling from the Community Tracing Collaborative, that's one thing. But if I say, calling from the Community Tracing Collaborative, and I also work in your community at Fenway Health, then people start to understand, okay, this really is a community collaborative. And I'm familiar with some of these names and these voices. Who have we hired? What does our workforce look like? We've hired case investigators, contact tracers, and resource coordinators. Very briefly, our case investigators and contact tracers, those are the folks doing the daily work of receiving positive test results, making an assessment of how those folks are doing, all through scripts and protocols designed and approved through our DPH colleagues. But helping us collect the information we need, gather those contacts, and then most importantly, and I can't stress this enough, most importantly is then tying something like 15% of the individuals that we reach to our care resource coordinators. And those folks, the resource coordinators, are coming with nursing or social work backgrounds, and they are connecting those individuals back to the resources that exist in their community, or identifying gaps in those resources and trying to come together in the spirit of mutual aid and things like this to fill those gaps and provide those resources. And I can't stress enough how important the resource coordination is. One of my first and most important lessons working in the Ebola epidemic is you won't have success in quarantine and isolation using force and fear. They're extremely ineffective tools in public health. The most important thing is education, and then providing for the dignity and basic human rights of those individuals that you're asking to quarantine and isolate. And I'll also say that in my experience, the act of quarantine, this idea of social distancing and stay at home orders, those things are usually acts of privilege, right? There are many people who are not able to stay at home and to quarantine or to isolate. And so it is the role of the tracing collaborative and the care resource coordinators to try to pull those resources into the homes and living spaces of individuals who need them so that they can safely quarantine and isolate. And I'll just touch on one last thing about the PIH work, is that, I don't think as an organization we'll be accused of ever waiting too long to get started. We and Derek and I had a nice conversation about this earlier in the week, and that, sometimes you have to start before you're ready. So this for us is an iterative process, as so much of our work around the world is. And when we receive requests and questions from other states or other municipalities saying, like, what is it that that was able to catapult Massachusetts? And I think it was the spirit of having to start somewhere. So we were able to do that and continually reiterate. And that's been through listening to our local health departments and understanding when we're not meeting their needs. It's really hearing from the folks that we're serving. And then also, I think, to tie this to community health workers, we've been really engaged with, for example, MACHWA, the Massachusetts Community Health Workers Association, who, we've sort of shepherded those individuals through the hiring process so that we do have community health worker representation in our workforce. But part of that then has become the accompaniment of other states and other groups. And you can see some of that, what some of that work looks like here. And just trying to help others sort of catapult in this way, even if they're not quite ready yet, to try to build out those workforces and think through, potential models for contact tracing in those states and those cities, as well as understanding, for example, with the Coalition of Immokalee Workers in Florida, the unique challenges of that population and sort of how that the cross-pollination of those challenges and potential solutions, for example, in Navajo Nation, where PIH works. So really, more than anything, trying to share lessons learned, try to provide a little bit of a catalyst for others who really do understand the importance of contact tracing as an important pillar in a public health response to an epidemic like this. So I hope that provided a little bit of framework and a little background for what PIH has been up to.
Thank you. Yes, thank you, John. Really, you're in the position where we've asked you to distill already not only a long journey and wonderful history of Partners in Health, but also sort of this whole ramping up that's happened here in Massachusetts and models that are now being set up and working elsewhere in the country. So Shreya Kangovi, Shreya has a lot of knowledge about certainly what John is talking about, but has clearly some thoughts and about the workforce issue here in terms of achieving the goals as well, including what Derek was talking about at the outset around equity. So Shreya, we welcome you and talk to us about your work. Thanks.
Sure. I'm actually not going to start with the work. I'm not going to start, at that high level as John did such a great job doing. I'm going to start with the ground level. And I want the listeners on this webinar to just imagine what life looks like on the ground for a lot of Americans who are living in some of these hardest hit communities. So imagine that you are Maggie, who is, let's say, a 43-year-old woman who lives in Newark. Let's say you work in retail and you're supporting your family. Maybe that includes an aging mom, teenage son, and you've lost hours because of the COVID-19 pandemic and you're barely making ends meet. Your landlord is breathing down your neck. Your asthma is starting to flare up, but in the midst of all of this, your doctor switched to telehealth and you don't have a smartphone or internet access at home. You finally do get to work and, you get pushed around by your 22-year-old white manager who sort of treats you like you're less than. And you have to watch videos of police officers stepping on Black men's necks until the life leaves their body. And you're worried that your son is going to get stopped by an officer on his way back from school. And now imagine you get a call from a contact tracer and she says that you've been exposed to COVID. I hope that feels heavy because it should. And I just want to acknowledge that, I really do appreciate Derek's framing of this conversation around equity. I'm going to speak with a lot of passion and anger in my voice because I am worried actually that what we are doing with all the best intentions in public health risks actually perpetuating inequity for people like Maggie. So, I tell that story of Maggie because I think it highlights all of the different issues that we read about in our headlines separately. You know, we read about COVID-19 infection, we read about police violence, we read about chronic disease disparities and food insecurity. And these are the issues that are killing Americans. We know that, you know, there are an excess of American deaths right now. And it is not just about the COVID-19 infection, but all of these other root cause issues that have always surrounded people like Maggie. So let's connect the dots. These are not separate issues. These are symptoms of an underlying pandemic of systemic inequity and injustice. And what people like Maggie Wright need at that moment is not to be, I think, educated about quarantine. She needs someone to lean on who actually understands what she has been through and can actually provide concrete support. And this is who community health workers are. These are individuals who share life experience with the people they serve. So like Maggie, they know what it's like to face discrimination, live check to check, survive community violence. They have been there and they get it. They are also natural helpers, as they're described by sociologists. They're individuals who have a high level of innate altruism. So, you know, they're dropping off soup to a sick neighbor, whether they are asked to or not. And so their approach to somebody like Maggie is qualitatively different from even the best trained, you know, the most well-intentioned individuals who just don't have that similar life experience, right? So first of all, they're not just trusted based on the fact that they may share a similar kind of demography or skin color. They're trusted because of who they are and the approach they take. They don't talk to Maggie, they don't talk at her, rather. They listen to her. They get to know her as a person. They say, you know, Maggie, things are hard right now. How are you? Tell me what life is like for you right now. Let me get to know you as a person, get to understand, you know, the strengths, challenges, and then let's figure out what I can do to kind of help you through this. They're advocating with her employer. They're battling that eviction notice. They're dropping food off on the porch, and they're often organizing their communities. And this may or may not have to do just with COVID. You know, in St. Louis, after Ferguson, community health workers were an integral part of the shift from policing as an approach to crime to community engagement. They would actually ride out with officers and meet victims of crime. And instead of, you know, taking that typical top-down paternalistic approach, they would learn who people were and understand their strengths as well as their challenges and provide community-centered, tailored support. And so I think that is really what is needed right now. You know, community health workers are, it's been a little shocking, I have to say, to see how neglected they have been as a part of this conversation. I appreciate John's opening with community health workers, and Partners in Health has done an incredible amount with community health workers globally. In the United States, community health workers are a bona fide workforce. They exist. This is, you know, it's been interesting to kind of hear about, you know, public health searching for community health workers anew and kind of looking around to see, you know, oh boy, I wish we had this tool that could really nail, you know, these things to the wall. That's a hammer. It exists, right? So community health workers have been hired by U.S. healthcare organizations, community organizations, public health organizations for the past 80 years to provide, again, that holistic and tailored social, economic, behavioral, and preventive health approach. There is a science and a practice to this. My team at the University of Pennsylvania, as Derek and Madge explained at the top of the hour, have developed a standardized approach to how do you hire the right people, because that is critical. It isn't just about training. You can't train to be a CHW any more than you can train to be a poet or a priest. It's a calling. And then, of course, you know, there is some training, but it's at all levels. It's for CHWs and the supervisors and the infrastructure in which they exist. And then the work practice. And so we've kind of standardized that up, tested it in 3 separate clinical trials, which have demonstrated improved mental health, improved access to care, improved chronic disease control, and a reduction in cost for about $4,200 per Medicaid beneficiary. So there's really quite a body of evidence behind this. There's a body of practice. We have a network across 20 states where we support organizations. in optimizing or building their community health worker programs. The National Association for Community Health Workers is a member organization that is incredibly well connected to state and local chapter associations, such as the Massachusetts Association that John mentioned. So there really is, the stage is set for this workforce. And honestly, 3 months ago, when the COVID-19 pandemic hit, my team and I were thinking, this is prime time. This is the moment to really elevate individuals from within these communities, to center them, to listen to them, to hire them, to acknowledge them. This isn't really just about, we often talk about these communities as vulnerable, which I reject. These are very resilient communities. They are systematically disadvantaged because of centuries of systematic oppression, but yet they have these amazing resources and assets and people like community health workers who are, both earn that title by virtue of very challenging life circumstances, but they are also the highest in terms of qualifications to then turn around and support individuals like them in addressing similar circumstances. And so what they can do, and what they are doing across the country, are mobilizing across all of these different fronts of the pandemic of injustice. And that, again, is going to look really different. Community health workers are very flexible. So any given community health worker, for example, could support Maggie's ability to self-isolate. She can also support her ability to manage a chronic disease or get connected with high quality primary care. Community health workers, like I said, can play a role in shifting police engagement strategies with the community. So this is really bread and butter for this workforce. I think what we need to talk about is, why haven't we had this conversation, and why aren't we having these conversations? I read with interest the New Yorker article, very pleased to see, the amazing work of partners and of contact tracing being highlighted, but it's really scratching my head. And I think we need to ask ourselves questions about systematic bias and why community health workers have not been placed at front and center of this conversation, hired and scaled up the way they should.
Thank you. Sorry, my microphone here on top of my head, not very helpful there. Shreya, thank you very much. And, I think that Don and Derek, and maybe some of you in the audience who's been with us since we started these programs, in particular at the end of March, we are actually, I think what's happening is actually these discussions at some level are happening. And it's really, I think, maybe the stage is set for now very, very different activity. And certainly, I think, Shreya, your framing of a lot of the issues is very much in line with what's going on right now. I think people are certainly highly sensitive to kind of solutions that are only really sort of taking in one part of the picture. So I want to say that I want very much, I've got a little spot here for John and Shreya to talk about challenges. I think we wandered into that space, no matter what. That always happens. I'd like to bring Don Berwick in for a moment here. Don's always a big listener to these kinds of conversations, as is Derek. But I'll go to Don right now for some thoughts, and we'll get to some of your comments and questions then in the chat. Don?
Yeah, thanks so much, Madge and Shreya and John. Thank you for those remarkable introductions, extraordinary thoughts, and an amazing use of public health science in a way that's really effective. I have to admit, I have a personal connection to this because my brother is a contact tracer with Partners in Health in the Massachusetts arena, and for the past month or so, more than that, he's been calling me almost every day about the experience. It's been wonderful. And to Derek's earlier comments, it's really been interesting as he tells me about reaching out to people how open they are. This has been set up in a way that he finds much less fear and rejection than he had initially feared, and he's having a great time. That's due in part to the way this is set up, as John explained. So trust is built from the start. And I loved Shreya's broadening of the frame to the real life circumstances of these people. Two quick comments. One is, just to be a wonk for a minute, what's going on here is really interesting because we're just connecting back to science in part with the contact tracing piece. I mean, this is stuff that's known, it's been proven, it's been documented. And when we really get scientific about the correct approach to dealing with tough problems like this, things happen. And I feel so troubled by the backing away from science as a foundation for public policy and public work here. Partners in Health and the contact tracing work there is just showing the power of connecting back to facts. This is a more general issue that Shreya has really talked to about as well, which is a broadening of the notion of public health itself and a reinvestment in public health as an enterprise in our nation. We know the proportions of investment to public health versus curative medicine. We need the curative medicine, but without an investment in the infrastructures of which contact tracing is part, what do we expect? We're going to get caught on our heels over and over and over again. So hopefully this will be reflected in public policy up ahead. This is what Carl White calls healing the schism between viewing the population and how we help them and viewing the individual through the lens of the interventionist healthcare system. I think that there is this broader context that Derek has flagged about equity and justice, and hopefully we'll talk a lot more about that, because unless we get into that, as Shreya was warning us, we aren't going to make progress in the long run. But for the short run, this is a real step forward, Madge, and I appreciate our guests.
Thanks, Don. Well, I would like to do this. I know where are we here? I'm looking at the clock. Let me just, starting with you, John, just take a minute or two, and I know, because I do want to make sure we can plug in some of the questions people have, but what are your thoughts in particular, let's say, about kind of workforce, and as you're listening to Shreya, thinking about what Partners in Health is trying to do to guide this effort. Anything you'd like to share now, that would be great.
Sure, yeah. And I certainly appreciate Shreya's succinct framing of the importance of community health workers in this fight and for so much of healthcare back to the community. One of the things that we've really seen is that our country does not have a good understanding as a whole of what public health is, right? This has been decades of sort of defunding and decimating the public health infrastructure in our country, and I think that also includes investment in and amplification of community health workers. I'll give a quick shout out to my sister, who is the director of communications at the Healthcare Collaborative of Greater Columbus, who partners with community health workers, and has told me since the beginning of this, saying over and over, we have a workforce who can do this work. This is what we do. And so, that's especially from PIH, it's a resounding yes. I think the complications in building a workforce come in trying to, and I think this goes back to why we've partnered with so many and subcontracted with so many community health centers. There was a potential for some of those community health centers to essentially go out of business due to lack of reimbursement during COVID, and needed funding from the state, which was provided from Massachusetts for a number of community health centers. We shouldn't be in that position. A community health center should never be in a position of going out of business the community health centers are should be the backbone of that health delivery at the at the community level. And I think that's one of the, with the tie out to the community being those community health workers. So I think our challenge and kind of what I was alluding to before was this idea of really starting before everything was perfectly fleshed out in a way that was trying to identify not just scale and speed, but also high quality. And so we're constantly refining that. And I think we with our work with Matchua, bringing in community health workers, and also understanding where perhaps we're falling short when it comes to the work that community health workers provide is so important. But also, I think it does speak to the fact that there's been a general attempt to solve contact tracing with technology. Right? There's been a push by so many to build an app or to just create a technological solution. But and I think Shreya would agree with me that all of this work can be technology supported, but it has to be human driven, right? There's no replacement for an empathetic ear. And I think that was sort of Shreya's point in that it's more than providing information about what safe isolation and quarantine is, but being that empathetic ear. And I think the value that the community health workers bring is the shared lived experience. And certainly, those systematically marginalized populations would have reason to not trust a stranger to call and just start sharing information without question or without any sort of suspicion. And those are our challenges that we've seen, and it's only been through the partnerships with community health centers and others to really make an impact in those types of communities. And it's for all the reasons that Shreya mentions. Right? It's that shared lived experience, and you can't train folks to navigate those situations. It does have to be a calling. So our work now is refining the system in this program to be able to reach those communities in a meaningful way, because I think that we'll continue to see, especially, Massachusetts, the numbers have trailed off for the time being, and I hope that they stay there. But I think that we're going to continue to see that traditionally the systematically marginalized communities will be the places where transmission continues, and I think that is a reflection of structural violence and structural inequity that we have to organizationally, but also globally, right? As a society, we have to recognize that it's our responsibility to move resources where they're needed, not just for COVID. I think I appreciated that about what Shreya was mentioning as well. This is not a COVID problem, right? Mm-hmm. It's simply a spotlight of centuries worth of inequity. So.
All right, thanks, John. Let me, Shreya, thank you very much, John. It's hopefully our program today can, I don't know, is helping to lay more groundwork, thoughtful thinking and approaches. And I really welcome anyone on the chat right now of how you can imagine maybe some of these things coming together in the community. I guess, Shreya, the question I would ask you is whether or not linkages with community health centers is part of how does that, does that actually link with community health workers as well? Is that, or is that one piece of a puzzle?
Yeah, I think it's it's certainly important to funnel resources into community health centers. I'm a primary care doc. I see patients in a FQHC in West Philadelphia on 52nd and Haverford, and so appreciate that. But I do want to point out that community health centers, departments of health, ministries are not the same as the people whom they serve. There's a disconnect between organizations and the leadership of organizations, and again, people like Maggie, or the person who's kind of living in a rural community outside of Bristol, Tennessee, or an undocumented farm worker in Immokalee. So I think actually what is really magical about community health workers is that they are those people. They are those actual people. They are not just about the titular and organizational structures that kind of exist in the community-based sector. They are the actual people. So this is not about a niche workforce. This is really fundamentally a people's movement within healthcare. We talk a lot about anti-racism. We talk a lot about health inequity. This is a strategy. This is an operational strategy to actually be anti-racist and fundamentally about social justice within healthcare. Appreciated Don's comments about public health science, and just to kind of underscore that, I'm a public health scientist by training, and what I was taught about public health is that yes, it is about epidemiology, but public health is also about the science of community engagement. That is as much, social and behavioral science is as legitimate and as critical a set of sciences than, as, biomedical health science, which we tend to anchor on. And yet we aren't thinking about that. My team and I have done 3 randomized control trials, and that is just a drop in the bucket of randomized control trial data that exists in the United States, supporting the effectiveness of community health workers to move needles that doctors and nurses have struggled to move, yet we are not talking about them. So I think we need to really, again, scratch our heads and ask ourselves, I just want to look around the room, figuratively speaking, and acknowledge that in healthcare and in public health, solutions are designed by and for privileged people. This is a time in America where we need to have the uncomfortable conversations. And I'm looking around this room, and this is a predominantly white, very highly educated group of people who live in privilege. And we are sitting here talking about what people like Maggie need. I think fundamentally we need a different approach. I'm not saying that we have the perfect solution at Penn or in the impact model, but I do think one of the things that has been really helpful for us is, a decade ago when we started doing this work, we started by interviewing 1,500 individuals, people like Maggie, and asking her, Maggie, what makes it hard for you to stay healthy, and what should we be doing differently? And that's what we use to design impact. And actually that question of, Maggie, what do you need in order to improve your health and your life right now? That's still at the crux of what every impact community health worker asks a patient when they first meet. So let's get real with ourselves. Let's be very careful about co-opting community health workers. I think that can happen in any number of ways. We talked about nurses and social workers playing this role. And I was upset to read in the New Yorker article, the author of that article called people who are doing contact tracing sort of absurdly overqualified. And what that means is that they have a lot of fancy letters behind their name. But those people, no offense, Don, to your brother, are actually underqualified if the core set of experiences, skills, and traits that are needed are a lived expertise and a natural altruism and a fundamental kind of empathy. that's who we hire. And I put into the chat a Harvard Business Review article about, how do you actually look past our biases around resumes and CVs, and it filters every layer of our hiring processes is biased. And how do you skip all of that and say, okay, what problems are we trying to solve? And what are the traits that are needed in order to solve those problems? And how can we hire those people and look past all of the other extraneous layers of bias? So I think that's one area we have to be careful about co-opting. And I think we need to, just be careful about either having other folks do all of the roles that community health workers do, but not calling out community health workers as the frontline workforce that should be doing those functions, or conversely, calling people. And I don't think anybody, just to be clear, on this panel has done that. I think I really want to credit Partners in Health with actually calling their CRCs, not calling them community health workers, because they're fundamentally different people who have similar roles that they perform, but community health workers are a noun. Contact tracing is a verb, health coaching is a verb, navigation is a verb, but community health workers can do all of those different functions, but have that unique identity that really allows them scientifically to actually do a better job. So actually, they're the ones that are qualified for this work. What's critical, just briefly, is, in the kind of getting into the challenges section is, okay, hopefully I've convinced everybody on this call, look into community health workers a little bit if you haven't really, been aware of this workforce. But you need to do one level more than that, which is, it's not just about awareness and, okay, we're hiring a community health worker. These programs have been around for a couple of 100 years, and they're tricky to get right. And so I put into the chat a New England Journal Catalyst article about the core elements that are actually required, we think, for success. And this comes from the global implementation science as well as domestic. And it's about, again, hiring the right work practice, and it's about the infrastructure, making sure we have supportive supervision, manageable caseloads, appropriate holistic work practice. And this, I think, is going to be in the conversation around how do we take this immediate opportunity to sort of build a public health workforce and actually build one that is set up for long-term sustainability and success.
Thanks, Shreya. And I want to also acknowledge the tremendous discussion and back and forth going on in the chat, where I think people see, in some sense, the contradictions, the possibilities, as well as some of the limitations right now. And all of us, everyone on this chat, is really at the intersection of really making things different and understanding. There's questions about financing. Shreya wrote a really terrific piece recently in Health Affairs. It's quite comprehensive. I tried to throw in that link there that Patsy on the chat also found one of your more recent pieces. And Shreya, some folks want to pursue you, and I don't know which inbox you want to provide, but you can maybe let us know that, and we'll put that in the resource information if you don't have a ready inbox for everything now. But I think folks want to talk to you and, of course, learn more about the work. I think that contact tracing, in one way or another, I could be wrong, John and others, is going to be with us for a while, and maybe optimistically, I might say, could only get enriched by everything that we're also talking about today. So we are mindful of time, and don't you know it, an hour can really speed by. I want to bring Derek back in to talk about Juneteenth a little bit. But also, Derek, one of the questions I wanted to throw out, because of sometimes who our audience really represents, is there a way that the healthcare system, this big behemoth system, we were talking a little bit about community health centers, health systems can often move ideas and attitudes too. So if any thoughts on that, Derek, feel free. Thanks.
Thanks, Madge. So it's clear from the chat that what John and Shreya have said has struck a chord with people. And if you are from a health system, we'd like you to advocate. We'd like you to go and speak to the public health department and your local politicians and advocate for contact tracing in the way that John and Shreya have described it. Just a few. I chatted some of this in, but just a few things that kind of struck me. John's point about how this needs to be in the community and done collaboratively seemed really important to me. And so if you are from a health system and you're going to advocate, then talk about those things. And Shreya's point about how if we designed this for Maggie, it would work for everybody seems kind of thoroughly important and central to your initial point, Madge, about equity. If we can get contact tracing to work for Maggie and her neighbours, it'll work for everybody. But the only way we're ever going to do that is to find Maggie, talk to her, and figure out what she needs. So that's what I would ask our health system friends who are on the call to do. Go and have these conversations in your communities. And if you need some help, I'm sure John and Shreya would be willing to help you, or come to us at IHI and we'll make the right kind of contacts for you. I didn't want to, as you said, Madge, I just did want to just finish the call with another reference to Juneteenth. So for those of you who are not familiar with it, it's the oldest nationally celebrated commemoration of the ending of slavery in the US. It goes back to the date on the slide there, June 19th, 1865, which is when Union soldiers entered Galveston, Texas, with news that the war had ended and that the enslaved were now free, news that had been kept from the people of Galveston, Texas for 2.5 years. And so that's why we have chosen at IHI to make this one of our public holidays. This year and in the future. We already had this program scheduled, and so we wanted to honour our promise to the folks who had registered and continue with the program. And the other thing I wanted to signpost you to was this article, which is on IHI.org and has been written by our Chief Human Resources Officer and Chief Operating Officer, Tamsin Jones. It's a very powerful and personal piece that Tamsin has written that has not only resonance to Juneteenth, but also resonance to the conversations that we've been having today about people like Maggie. So thank you to our experts today, to Shreya and to John and Madge. I'll hand back to you to close.
Well, we have reached the, thank you, Derek, and we've reached the end of our time together. With it, we had more hours to hash more of this out, but there is so much more to learn, and I do invite you to take advantage of all the resources. If you didn't get a chance to look at the New Yorker article about what's been going on with Partners in Health, and, you know, warts and all, some of the amazing feat of mounting all this in Massachusetts at an earlier stage, and now all the learning that can help continue to shape and reshape what's possible and engage community health workers. So there was a survey, I think it's still hanging around there, which if you could fill out, that helps us know how we've done bringing all this to you today. I want to extend a big thank you to John Welch, Shreya Kangovi, Don Berwick, and Derek Feely. Also thank you to Nina Lewis from IHI, who helped behind the scenes with today's program. Thanks, audience, for taking the time to participate and for all your thoughts and contributions. You can find the entire show and all the related resources on our website at the very latest by Monday. If you feel like taking a peek over the weekend, you might find it there too. We're going to be back, believe it or not, next Friday at this time. And we're continuing on with the thread that we're working on, which has to do with caregiver mental health and well-being. And that's a collaboration with Wellbeing Trust. And details will soon be available on IHI.org about that. So we wish you all the best, and we honor Juneteenth with all of you, and good health, of course, for the Institute for Healthcare Improvement. I'm Madge Kaplan. Have a good day.